Hello, everyone. Thank you so much for joining this special educational session. My name is Sadaf Altaf, and I am representing the Global Health Supportive Care Working Group. My co-chair is Miguela Caniza, who's also here with me. She is my co-moderator for this session. And we are going to be, we have a very special session with some very unique topics that we're going to be covering today. So the format of the session is we have 3 talks, and the first talk is focusing around physical medicine and rehabilitation. The second one is going to be around blood safety and proper utilization of blood products in pediatric oncology. And then the last talk will be focusing on the management of febrile neutropenia during this pandemic. And without wasting a lot of time, I would like to invite my first set of presenters. And I would like to introduce to everyone 3 fantastic colleagues who are experts of physical medicine and rehabilitation. And they have been identified as a new task force within SIOP, and they are currently under the umbrella of the Supportive Care Working Group. We hope that, they become a working group eventually on their own, identifying the need for physical medicine and rehabilitation in pediatric oncology. So we have Pia Delano from Chile. She's a physiotherapist. And she works in Santiago. We have Abu Sidhanee from UK. He's also a physiotherapist, and he works at University College Hospital in London. And then Annie Brochu from Canada. She's also a physiotherapist. She works at St. Justine Hospital in Montreal. And I would like to invite my colleagues to start their presentation.
Thank you, Sadaf, for that introduction. Well, as Sadaf mentioned, we are working to create this new rehabilitation task force. And today we're going to be talking about the role of physical medicine and rehabilitation for holistic cancer care. First of all, we have nothing to disclose. And as Sadaf mentioned, we are 3 physiotherapists from different parts of the world. And we have been trying these last years to form this new SIOP rehabilitation task force that is becoming a dream right now to be here with you. And today we're going to be talking about first what rehabilitation in pediatric cancer means, the strategic significance, and the initial aims of this new group that we have been working on. So, a brief introduction of what childhood cancer rehabilitation entails. Well, I'm Pia Delano. I work at Fundación Nuestros Hijos in Chile. And rehabilitation means a set of interventions designed to optimize functioning and reduce disability in individuals with health conditions in interaction with their environments. So rehabilitation actually entails 4 different groups, 4 different parts, which is the physical rehabilitation, and which is the most visible one, and also the cognitive aspects of rehabilitation. There's also a social aspect in rehabilitation and an emotional one. And we will be talking a little bit about them. But why rehabilitation and pediatric cancer? How do they go together? We know that well, more than 90% of patients during treatment present different symptoms such as pain, neuropathy, and fatigue. And these symptoms don't always go away once the treatment finishes, which is why more than 80% of survivors refer to have at least one type of sequel or side effect related to their cancer or the treatment. And these sequels and side effects appear even 10 years after finishing treatment. So it's something that we need to find a way to prevent. And what is going on is that there's going to be a rise in diagnosis and treatment worldwide, which will mean that we will have more survivors. And we need to be prepared because almost 100% of these survivors will need some type of rehabilitation. But what does the pediatric cancer patient needs? Well, actually, there's no a guideline of what the patient will need because it will depend on different factors. For example, the age. It's not the same to treat a little baby than to treat a 15-year-old. They have different needs. They have different social roles. They have different motor skills and cognitive function. So we have to be prepared to treat a patient from different age range. It will also depend on the type of cancer that the patient has. It's not the same, of course, a leukemia patient with a brain tumor. Clearly, the brain tumor patient will have more sequels or side effects, and they will be more obvious to us than, for example, a cognitive impairment in a leukemia patient. It would also depend on the treatment that the patient has, whether it's only chemotherapy, it's chemotherapy and radiotherapy, or surgery, especially amputation surgeries. They have a clearly an obvious functional impact in the patient. And finally, of the context of the patient, the support system, whether the family is involved or not, is he an only child or does he have siblings? Siblings become a very important and motivational aspects when you are rehabilitating a pediatric patient. So they tend to keep more active during treatment than those that do not have siblings, for example. And also we have to aim for the patient to keep going to school while in treatment. So the context is very important when we are talking about the patient needs and rehabilitation. So since we have this huge spectrum of what a pediatric cancer patient may need, it's important to have hopefully a full team prepared to treat and rehabilitate these sequels and side effects that may present in this patient. This is, of course, our ideal team. We know that not every facility has all these professionals, but we definitely suggest that they should, especially having a physiotherapist, occupational therapist, speech therapist, neuropsychology, psychology, and education, so that patients do not suffer from the treatment and do not suffer at school. And when we look at this from a system approach, one of the things that we may find and that we will treat is, for example, in physical aspects, is to diminish pain and fatigue and to improve the functionality, like in general terms. In the emotional system, we have that we need to help them cope with the diagnosis, with the fears and the pain that may happen during treatment. And with the process, the different processes that come with being diagnosed with cancer, like losing your hair or moving you from school. In terms of cognitive system, we need to improve cognitive skills or to adapt when they are affected due to treatment. For example, patients with brain tumors that undergo surgery, they may have some difficulties in their cognitive skills, so we need to teach them how to adapt to their new reality. And of course, the social role, we need to restore the social role, which rehabilitation takes a very important part in restoring this, especially because we basically take the patient out of his social environment and we put him in a hospital during a period of time. And we need to be able to put the patient back in his social context, just as he was before. And all these professionals and all of us, we're working for the same goal, which is, as one of my patients once told me, that cancer is only one part of your life and not your whole life. I think we're all working so that cancer becomes only that phase of your life, of disease during your life, but that the sequels and side effects do not go with you for the rest of your life. And that's what rehabilitation aims in this population.
Hi, good day, everybody. It's an absolute pleasure to be here to present to you today. My name's Sidhanee. I'm going to talk to you about the strategic significance of cancer rehabilitation. So I'll talk about what we know. I'll talk about the economic impact. I'll talk about the human impact. And then at the end, the most important thing about the significance of it all. So what do we know? we know that global survival for children's cancer is improving. Epidemiological transition means the relative burden of childhood cancer will increase. So as conditions, for example, such as malaria improve, we'll see a relative burden of other conditions such as cancer increasing. Through initiatives such as the WHO's Global Initiative for Children's Cancer, we should see more high quality children's cancer programs globally. And the GICC's goal of 60% survival by 2030 represents doubling of the current cure rate, and it will save an additional 1 million children's lives over the next decade. So we all know there will be more survivors of childhood cancer. But the important thing is that rehabilitation will be the key to optimizing quality of life. Cure isn't enough. We need to do more. We need to ensure that apart from allowing the children treatment and survival, we help them to achieve everything that they would want to be able to do. So the WHO has some information about rehabilitation, and I don't think any of it will be a surprise to anybody listening to this today. Globally, about a third of people live with a health condition that would benefit from rehabilitation, and this need worldwide is predicted to increase. However, numerous countries are not equipped to respond to the existing rehabilitation needs, let alone the predicted increase. And in some low and middle income countries, more than half the population do not receive rehabilitation services they require. And we know the rehabilitation is often not prioritized and continues to be under-resourced. So in 2017, the WHO launched a Rehabilitation 2030 initiative, and that initiative highlighted the unmet need for rehabilitation worldwide. It emphasizes that rehabilitation should be available for all of the population and through all stages of the life course. So this is for children and teenagers as well. To reach its full potential, integrating rehabilitation into all levels of healthcare and strengthening healthcare systems as a whole is required, and that rehabilitation should be considered as an essential service. This is a big number. It's $1.16 trillion. And according to the WHO, this is the annual economic global cost of cancer. But what can we do to offset that cost? So some of you may be familiar with this infographic. It was published last year in the Lancet Oncology Commission. The red represents treatment costs, and this infographic tries to demonstrate that for a relatively small amount of treatment cost, a society or an economy will gain that back in a huge amount more of productivity gains. So putting a little bit in gets a lot more out. But without rehabilitation, it's probably not really that amount. If we just cure children, but don't allow them to fulfill meaning relationships and take on roles within society, are we really going to see that productivity? If we do put in rehabilitation, however, the picture could be very different. We could see huge productivity gains, more than maybe we'd even considered before. I'm going to now talk about the human impact. So what is the impact on the child, the family, the friends, and the community of not only curing a child, but being able to help them to walk again, to play, to be able to get to school, to gain an education, to make meaningful relationships, and potentially have families of their own? This is the easy bit. I don't need to put too many slides up. We know that we're in an audience here where I think you all understand this, and you don't need convincing that the human impact is absolutely huge. In 2019, I attended the Congress in Lyon, and I was very privileged to see a video called How I Live, which involved some families across the world who are undergoing treatment for cancer. And a mother from Egypt described her child accessing treatment as being bigger than the distance between the earth and the sky. And I can't put it any better myself. I think there are no words to describe the impact we can have from not only just treating, but rehabilitating a child. And I know, again, in the company that we are in, this is not something I think I need to convince, or we need to convince any of you of. We know that giving access to children all over the world to enable them to have treatment and a cure is the right thing, but also I think we know that enabling them to fulfill their potential is also the right thing, and we will always aim to do that. So what is the significance for all of us? And this is not just for me, Pia and Annie, but for all of us, all of you listening. It is that now is the time to raise the profile for rehabilitation. Now is the time to build networks and alliances. Now is the time to politically advocate for rehabilitation. Now is the time to develop infrastructures, and now is the time to build the evidence base for rehabilitation. And to summarize why is this important? Globally, there is the potential to optimize the function, quality of life, and physical and psychosocial outcomes of millions of children. And this, in turn, has the potential to have hugely positive impacts on the lives of millions of families, the burden on health resource, and the socio-economic productivity amongst many other things. There's a few references for you. I'm going to hand over now to my colleague, Annie Brochu.
So hi everyone, my name is Annie Brochu and I'm a Pediatric Oncology PT at St. Justin's Hospital in Montreal, Canada. And it's an honor to be here today to present you the initial aims and objectives of the Rehabilitation Task Force Abu and Pia was talking about. So coming together under the SIOP Global Health Network Supportive Care Working Group. So like Pia and Abu just highlighted, rehab is really important for all, and we know it's key to better quality of life for childhood cancer survivors. So maybe you're wondering, how did we actually got here, Pia, Abu and I? Well, we met through the SIOP 2020 chat room a year ago. We were so happy we found each other to share our passion for pediatric oncology rehab that we wanted to spread the news. So from UK to Chile and Canada, thanks to emails and virtual meeting for keeping this group alive and growing. And we think our presence here today is a demonstration that there's a great interest in pediatric oncology rehab within the SIOP community. Next slide, please. So what are the Rehabilitation Task Force aims and objectives? First, we really want to bring together cancer rehab experts globally and in different languages. Je parle français, Pia habla español, and Abu speaks English, so that's a good start. But we also want to promote collaboration by sharing knowledge, education, and best practice regardless of the setting. But most of all, we really want to support colleagues globally and in settings where childhood cancer rehab is limited or an evolving area. So who the Rehabilitation Task Force should include? Well, since rehab is such an interdisciplinary thing, we really want to get on board occupational therapists, physical therapists, speech and language therapists, play therapists, physical medicine specialists, or actually any healthcare professional or physician interested in rehabilitation. So welcome to everyone interested in rehab in pediatric oncology from around the world, because someone once called us some rare unicorns, but we hope there might be more of us than we think. And it's really great to see that there are some presentation and posters on this important topic in Congress this year. So thank you for your attention, and please get in touch if you're interested to join the Rehabilitation Task Force. Thank you.
Fantastic. Thank you so much for that lovely orientation and introduction. And I think we will have time towards the end for questions, and I encourage attendees to post the questions on the link provided, and we will be answering questions towards the end. I am going to ask my colleague Miguela Caniza to introduce our next speaker.
Yeah, thank you so much. And again, it's a privilege to be here, such a great company. And thank you, Sadaf, for all the introductions. And so Dr. Sarah Tessin, she's a transfusion medicine physician and pediatric hematologist in Saskatoon, Canada. So she has a fantastic background. So she did her pediatric residency in Michigan, her pediatric hematology and oncology fellowship at Emory University in Atlanta, and transfusion medicine fellowship at the Medical College of Wisconsin in Milwaukee. So her passion is about transfusion medicine, and especially in assisting places like, her own country, I guess. So, and globally. So we are absolutely thrilled to have her here. And so, Sarah, the podium is yours.
Thank you very much for this very kind introduction. I am going to go ahead and start sharing my slides. Please let me know once you can see them, and then I will start. All right. Thank you so much for giving me the opportunity to speak in this symposium today. I am going to be talking about blood administration safety and evidences for thresholds of transfusion in pediatric oncology patients, as well as stem cell transplant patients. The objectives of my presentation are to understand the rationale for transfusion of blood products, recognize the risks associated with transfusion, identify the transfusion thresholds for these patients, recognize areas of future research, and then a brief conclusion in the end. All of these sections will be preceded by questions just to make you all think about them and to solidify your approach to multiple transfusion scenarios that we come across in the pediatric oncology world. So I'm going to start with the rationale for transfusion in pediatric oncology, which is not going to be particularly surprising to anyone. But just to give you some perspective, a 10-year-old female in our case receives 5 days of etoposide and ifosfamide. She got her chemotherapy about 7 days ago, and today she had an epistaxis episode, which lasted for about 20 minutes. Her white count is 1, her hemoglobin is now 82, her platelet count is 10, and her absolute neutrophil count is 0.2. So then the question that comes to you as a pediatric oncologist is, what is the most appropriate transfusion strategy for this patient? And really, one of the things which play into the decision making is the general trend of platelets and the red cells after receiving cytotoxic chemotherapy. So the lines that I'm showing you are not a perfect description. For some patients, these are highly variable. But as a general rule, if your platelets are going to fall about 5 to 10 days after you receive the cytotoxic chemotherapy, and for hemoglobin, that nadir happens around, I would say, 14 to 17 days post cytotoxic chemotherapy administration. And that understanding is important because if you have a patient who is coming and is past the nadir, the counts may be improving and you may not have to transfuse them. So that knowledge plays an important role in that determination. And why do we transfuse them? Well, number one, obviously, to manage the chemotherapy-induced anemia, which can be quite severe and interfere with actual function and oxygen delivery. To overall improve the symptoms and the quality of life management in pediatric patients. For the platelets, prevention of spontaneous hemorrhage, as well as facilitation of chemotherapy and permission for performing surgical procedures. Plasma products are not transfused routinely and really should be given in the management of significant hemorrhage. And we will talk more about all of these aspects in my subsequent slides. So really, when you're approaching transfusion decisions for pediatric oncology patients, you have to look at 3 things, right? First thing that you have to look at is the clinical picture. So is the patient symptomatic from anemia or is the patient symptomatic from thrombocytopenia? Secondly, you have to look at the evidence-based transfusion triggers if you're going to pursue prophylactic transfusions. And then finally, you have to look at the kind of chemotherapy that patient has received. And you have to see whether that chemotherapy is cytotoxic or not. And number 2, what is the time of chemotherapy administration and where the patient is at in terms of expected recovery of his hemoglobin and platelet counts. So for the patient in case 1, platelet administration is actually appropriate because she's very close to the platelet nadir and she had clinical symptoms of hemorrhage. For hemoglobin, it is appropriate to follow up, but she may require transfusion within the next 1 to 2 weeks. So moving on to risks associated with transfusion. And this is a scenario that I think anyone who has worked in the pediatric oncology field has probably seen. So you have a 5-year-old male with rhabdomyosarcoma, he's receiving platelets and develops hives, tongue swelling, chest pain, hypoxia, and cough after 15 minutes of transfusion. He does have a previous history of hives with the transfusion of platelets. So the question that you must ask yourself is, what is the type of reaction and what steps are crucial to prevent or mitigate this reaction? When we look at the rate of and the type of adverse events which occur with transfusion in oncology patients, this was a study that was published just recently, and it talked about 201 oncology patients undergoing about 3,200 transfusions. Overall, the rate of adverse events was 2%, which is actually lower than that of general population. Febrile non-hemolytic transfusion reactions were the bulk of transfusions. Allergic or anaphylactic were a significant number, and then 3% were circulatory overload. Reactions which required either a prolongation of hospital stay or a patient disability or increase in the level of care were about 5 of them. So 2 were circulatory overload, 1 was anaphylactic, and 2 were febrile reactions. Platelets were the biggest culprits, followed by the red cells. And this would be accepted based on the way the platelets are stored at room temperature, and because of the fact that they have a higher propensity of carrying cytokines, and then hence leading to more anaphylaxis and febrile reactions. So in your second patient, obviously you have to stop the transfusion, administer epinephrine and steroids to manage the allergy, which is going into that anaphylactoid category. To prevent the reaction in the future, pre-medication with antihistamines is recommended, as it does reduce the severity of reactions. It doesn't stop them altogether. In some cases, removing supernatant from the blood products and suspending them in saline called washing may be required. And then the third and the most important part is transfusion appropriateness. So what that means is that you transfuse blood products only in situations where clinical scenarios have shown that there is effectiveness. The benefits of giving a blood product exceed the risks. The dose is appropriate, and the product that you have selected for transfusion is also appropriate. So these are the things that must come to play when you are making transfusion decisions. When we talk about transfusion thresholds, majority of the data is actually derived from adults, but has been reproducible in children so far, and which is why it's fairly adaptive. So we talk about the patient in our third case, who is a 5-year-old male with ALL and consolidation, who is admitted for neutropenic fever. He got his last dose of chemotherapy about 10 days ago. And as you can see, his white count is actually a little bit increased compared to 4 days ago. His hemoglobin, however, has trended down from 89 grams per liter to 70. I'm using 70 instead of 7. It may confuse some people. It's a Canadian thing. So let me know if it is causing some confusion. But it's basically 7, 8.3, and 8.9. And the platelet counts are still somewhat stable, and as is the absolute neutrophil count. So what is the most appropriate transfusion decision? And in order to realize that, you have to look at the pediatric data. So TRIPIQ was a randomized clinical trial which was carried out in 2010. It looked at the transfusion prophylactic, meaning non-hemorrhagic, not hemodynamically unstable, not severely symptomatic patients, and pediatric intensive care units, and compared a liberal transfusion strategy where people were getting blood at thresholds of 90 or higher versus a restrictive transfusion strategy where kids were only transfused if their hemoglobin was 70 or below. They looked at 637 patients, and they looked at 28-day mortality as well as end organ failure. And there was really no difference in either of them by using a more restrictive transfusion threshold. TRIPIQ has been the big significant randomized control trial in red cells for pediatric population. It has led to multiple subgroup analyses, and this threshold of 70 has been adaptable into surgical and even pediatric cardiovascular patients, and has led to the formation of transfusion and anemia expertise or TAXI initiative, which provides transfusion thresholds for stable non-bleeding pediatric patients. So when we come to our oncology patients, there was one pre and post intervention study which was performed in the pediatric bone marrow transplant recipients, where they compared a threshold of 70 versus 100 for hemoglobin for the transfusion of red cells. They were looking at length of hospital stay, all-cause mortality, and time to engraftment. There were 66 transplant patients who were transfused for a threshold of 100, and 75 who were transfused for a threshold of 70. And they did not find any difference in mortality, length of hospital stay, or engraftment. And overall, reducing the number of transfusions led to significant cost savings for that facility. So when we look at red cells transfusion thresholds, the clinical context of anemia must be considered. And a transfusion threshold of 70 is safe for oncology patients. The dose is based on the hemoglobin you wish to target and the patient's blood volume, but generally translates to 10 to 15 ml per kilogram to a max of 1 adult unit, which is about 300 ml. And this should increase the hemoglobin by about 10 to 30 gram per liter. So for our case 3, the transfusion of red cells is actually appropriate. So when we talk about platelets, so once again, we have a 2-year-old male. He got his chemo for AML about 10 days ago. Has somewhat stable white cell count and hemoglobin, which is still hanging in 90s and 80s. The platelet count was 35 about 4 days ago and is down to 9 today, and as is the absolute neutrophil count. So first question that arises is, should platelets even be transfused prophylactically, or should they only be transfused in situations where there is hemorrhage? So this is based on adult data. There was a randomized controlled trial of 600 adult patients with cancer, and they recognized that in patients who were receiving platelets only for hemorrhage had more days with bleeding, which was fairly severe. They also recognized that these patients had earlier onset of bleeding from the time of admission. However, the severity of hemorrhage was not significantly different. The second trial, which compared appropriate prophylactic transfusion threshold, was also in adult patients, and it compared a prophylactic threshold of 10 versus 30, and it really did not see a difference in the number and severity of hemorrhage or mortality, which once again advocated for the lower threshold of 10, which is now the widespread practice. A unique group of patients are pediatric patients with acute lymphoblastic lymphoma who are undergoing lumbar puncture, and especially the diagnostic lumbar puncture. So the recommended thresholds have been anywhere between 50 to 70,000 count of platelets, because there is concerns not only for risk of spinal hematoma, but also for CSF contamination with red cells as a result of traumatic tap, which can then lead to, which can theoretically increase the risk of an ALL malignancy by leading to CSF involvement. This was a study that was fairly old. It came out in 2002 and looked at about 5,000 LPs and about 900 newly diagnosed ALL patients. And what they found was, in all the patients, when the platelet counts were higher than 100, the odds for hemorrhage and traumatic taps were lower. However, once the platelet count drops to less than 100, it didn't matter if your platelet count was 50 or if it was 30. The rate of traumatic taps was fairly similar and more correlated to a prior history of traumatic tap, a more recent lumbar puncture, and the overall training of the person performing the lumbar puncture. So as a general rule, based on adult data, in non-bleeding children, a threshold of 10 for platelet transfusions is very appropriate. In patients on anticoagulation, derived from adult data, threshold of 30 is considered appropriate. Lumbar puncture and moderate risk surgeries, anywhere from 50 to 70, and then neuraxial procedures or those involving CNS surgery, we use a threshold of about 70 to 100. The dose of platelets is 10 to 15 mLs per kilo and should increase the platelet count by 30 to 50,000 in a pediatric patient. So platelet transfusion is appropriate in our fourth patient. Coming to frozen plasma, which is the biggest culprit in all the transfusion-related problems. A 2-year-old male is in ALL, is in delayed intensification. He's admitted with Staph aureus bacteremia. He has no hemorrhage, upcoming procedures, or a high-grade mucositis with oral bleeding. His INR was noted to be 2 this morning. PDT was 35 seconds with a normal 5 minutes. So when we look at the evidence for plasma transfusion, there were about 13,000 pediatric patients who were critically ill across 61 countries. And they looked at the impact of plasma transfusions overall and the prevalence of plasma transfusions overall. And so it was a cross-sectional study, and really they found that plasma transfusion was not associated significantly with reduction in the severity of hemorrhage. Also, in terms of correcting the number, like the INR number itself, it only had value if the patient's INR was higher than 2.5 and a PTT was more than 60 seconds. When we looked at clinical outcomes in about 831 critically ill patients, recipients of plasma had higher mortality, length of stay, and end organ dysfunction. In that case, a unique situation is patients with ALL who receive asparaginase because it reduces the serum protein levels and causes a fall in antithrombin levels. It also increases tissue factor and promotes and leads to an overall prothrombotic profile. Dexamethasone increases von Willebrand factor and reduces fibrinogen breakdown, which renders these patients fairly prothrombotic and raises the question of the value of prophylactic plasma transfusions. There has not been a lot of data about it, but the studies that have come out have really shown that the prevalence of venous thromboembolism in the pediatric patients with newly diagnosed ALL after asparaginase therapy and dexamethasone is really not affected significantly by prophylactic plasma transfusion. And one thing which has shown a correlation with the plasma transfusion in these patients and with the risk of thrombosis in these patients is really the age and the NCI-ALL category, with the high-risk patients being at a higher risk of developing thrombosis. Prophylactic anticoagulation, antithrombin therapy, and fibrinogen are other things which can be considered for this particular group. But none of them have shown any significant benefits so far. So overall, plasma transfusion should only be carried out in the settings of clinically significant hemorrhage or surgery with a high INR, or if the patient is having massive hemorrhage, meaning that they lose about a third of their blood volume in less than 3 hours. So administration of frozen plasma will not be indicated in our patient, and he's most likely has DIC associated with his septicemia. Sorry. So there are certain questions which have not been answered so far in pediatric patients. So for anemia, in chronically transfused patients, we really haven't figured out how iron overload plays a role in their end organ function. And that is something which does need ongoing investigation and research. Erythropoietin and erythropoietin-like agents were used in the first few years of 21st century to reduce transfusions in adults, but significantly increased thrombosis risk. So fell out of practice, and we really don't know what kind of role they play in the pediatric patients. When we look at platelets and the risk of hemorrhage, we really haven't studied the value of tranexamic acid and other antifibrinolytics in pediatric oncology patients. However, these agents have shown a lot of benefit in non-oncology pediatric patients. We still need to understand the reasons for platelet refractoriness, in addition to HLA alloimmunization, and the use of thrombopoietin analogs to reduce the frequency of transfusions. And the last two things are pathogen-reduced red cells and platelets are a good option. Should they be used, and how widespread they are, and what is the value, and is it cost-effective? And lastly, real-time clotting assays and their value in predicting a true hemorrhagic profile for patients. I think it will play a very important role in determining who benefits from transfusion versus not, but it's still an area under research. So in conclusion, I will say transfusion appropriateness reduces adverse events and utilization costs. While the evidence for prophylactic transfusion thresholds are mostly derived from adults, they are reproducible in children in most situations and demonstrate safety. Thank you very much, and you all have a nice day.
Thank you so much, Sarah. That was really, really fantastic. I think we will have questions at the end, and I really encourage participants to post their questions. Without any further ado, I would like to move on to the last and very special talk in this session. And I will be introducing my colleague here, Dr. Miguela Caniza, and she has been, she's a resident of Paraguay, and she has been with St. Jude's Children's Hospital since 2001. She's also the co-chair of supportive care working group in global health with SIOP. And she's the director of Global Infectious Disease Program in the Department of Global Pediatric Medicine. And Miguela will be talking to us today regarding febrile neutropenia and its management in the during the times of COVID. So Miguela, the floor is yours.
Thank you so much, Sadaf. And again, it's a pleasure to work with you. So let me just share my screen. Can you see that?
Yes.
Okay. So I'm going just to expand. And again, thank you so much for this invitation and to be part of this group. And so when I was asking my friends, so we have a very nice network of colleagues who work in issues related to infection. And so I asked them, what would you like to hear? Because they assigned me to this topic, and these are the stuff they wanted to hear about. They wanted to know a little bit more about the epidemiology of COVID and cancer and febrile neutropenia, risk factor for severity of COVID in cancer patients, testing, co-infections, outcomes, treatment, prevention of COVID transmission during hospitalization and chemotherapy in COVID. So because of the time, it's very short, so I'm not going to talk about number 7 and number 8. Sorry about that, maybe for next time. So in regard to the epidemiology of COVID in cancer. So for this, we have very good early on, I would say probably half a year into the pandemic last year, Dr. Bouland from the Memorial Sloan Kettering published this very, very good paper that it gave us a glimpse about what is going on with pediatric cancer. And with his team, they screened for COVID-19 symptoms or exposure to infection with SARS-CoV-2. And so basically, they did SARS-CoV-2 testing by PCR in 3 cohorts. Those that were exposed to COVID-19 or with symptoms, those who were asymptomatic, and the caregivers. And so then they compare the group using the 2-tail Fisher exact test, and they found that they had 335 SARS-CoV-2 tests in children and their caregiver. So they resolved the pediatric patient, 20 of them were positive. And so that was 11.2%. And when they see on the group, so they found that close to 30% of the positive were those who were screen positive or symptom positive. And much lower was the number of those who were screen negative or symptom negative, only 2.4%. And then among those patients that they found, one patient with COVID-19 had non-critical care hospitalization for COVID-19 symptoms, 3 without significant COVID-19 symptoms admitted for febrile neutropenia, cancer morbidity, or planned chemotherapy, and 16 had mild symptoms, and they were managed at home. Among their care provider, 13 or 74 were tested. Of 10 patients who were tested positive, and importantly, they found that from that group, some of them were symptom and screen negative. And so those actually, we learned important lessons from the study. One of them was that the morbidity of COVID-19 pediatric patient with cancer is low. 5% require hospitalization for symptoms of COVID-19. The rate of SARS-CoV-2 infection among asymptomatic pediatric patients was very low, only 2.5%. But importantly, that SARS-CoV-2 infection in asymptomatic caregiver was very important, 14.7. And so, Dr. Bulat said that possibly the vulnerability of pediatric cancer patients to SARS-CoV-2 may be like other children. And we say, okay, so we got some information. So let us see now what are the risk factors for severity of COVID-19 in cancer. But before I dive into that, this was the clinical characteristic of SARS-CoV-2 infection in children, as that was shared with us by Dong and collaborator. And so he reviewed over 2,000 children, reported to the Chinese CDC, and then he basically put in this classification the severity level in asymptomatic, mild, moderate, severe, and critical. What he found is like the big bulk of patients were in the group of asymptomatic, mild to moderate, more than 50%. And so patients who require medical intervention, the majority were moderate infection. Very, very few were severe and critical and require advanced medical attention. Now, let us take a look at what are the stuff that we need to worry about when we have respiratory infection in the immune deficient patient. And I always say COVID is a respiratory infection. So it's similar to other respiratory infections that we are familiar with. And for that, I'm going to review briefly about this publication. And in this publication, he said that respiratory viral infection in immunocompromised patients are characterized by prolonged viral clearance, higher rate of pneumonia, late airflow obstruction, and mortality. And then also the tendency for upper respiratory tract infection to progress to lower. And the lower tract infection can be manifested as viral pneumonia or airflow obstruction syndrome. So the demonstration of risk factor for progression would enable us to identify who are the patients who could benefit from early treatment or be on the loop. And so the risk factor for progression to lower tract respiratory infection, are lymphopenia, other cytopenia, exposure to pulmonary toxins, and then a much sicker patient, presence of co-pathogen, high-dose steroid. And then the mortality risk factor are if the patient undergoes stem cell transplantation is the source of the stem cell, the oxygen requirement, much more immune compromised, much more sick, and cytopenias. And then Ogini and collaborator, they study human coronavirus. Remember, the SARS-CoV-2 is animal, but this the coronavirus, there is a human. And so he studied, and that was before the pandemic, they studied the shedding of human coronavirus in nasal sample as detected by PCR. And so he wanted to know which are the risk factors for prolonged shedding lasting over 21 days. And he found that among the patients that he studied, 17 of 44 had prolonged shedding. And so according to the analysis, the risk factor for high emission, high shedding were high viral load initially, receiving high dose steroid, and then the ablative bone marrow conditioning. And so, and that was very, very important that he found, because this is very applicable also for SARS-CoV-2. We are going to talk more about the shedding in the SARS-CoV-2. So let us take a look about testing, because that was another question that my friend asked me. And so in regard to testing, so the testing or the in vitro diagnostics, so that can be done, they can be specific viral diagnosis. Also, you can have serologic of antibody and other adaptive immune response tests. And then the other tests are for management of COVID-19 patients. Among the diagnostic tests, these detect part of the SARS-CoV-2 virus. And the use is to diagnose the infection with SARS-CoV-2. And the type, you have two types, the molecular testing and the antigen testing. So normally you don't do culture in this. In the serologic testing, detect antibody of T-cell response or T-cell response to SARS-CoV-2 virus. And the use is not for diagnosis of current infection, but past infection. So the types are IgM, IgG, and T-cell immune response. And then you have the test for the management of COVID-19 patients. These are tests to detect biomarker related to inflammation. And this, the utility of this is used to inform patient management decision. All these things are very important during the management of a child with cancer. In regard to the diagnostic or molecular testing, also it is called the nucleic acid amplification test of NATs. This detects the viral RNA gene. We call them the PCR. And they have very high sensitivity and specificity for SARS-CoV-2. So the NAT or PCR show a current infection or a recent infection. You can have persistent positive NAT, but it's not always direct evidence of replicating virus. Most of these NAT need laboratory, and time to results could be 1 to 3 days, but some NAT can be done as in point of care diagnostic situation, and in that way the result can come much faster. And most of these NATs or PCR produce qualitative results. They don't give quantitative. And this can be done in upper respiratory sample or lower respiratory sample. And here, just to let you know that there are so many of these. So there are about 251 tests approved by the FDA under the emergency use authorization. And here I put just some of them. And here is like the procedure to go. And of course, it requires a little machine, like in this picture. And then you have the other type of diagnostic, which is the antigen test. So the antigen tests are immunoassays that detect the presence of specific viral antigens. Sometimes they are proteins. And these antigens are less sensitive than most of the PCR. And most of them are less expensive than the PCR. And these antigen tests can be done at the point of care. And the results are available in minutes and useful for a screening program, for instance, before a trip, before a game, to find who are contagious. And the antigen test might need confirmation with a PCR based on the reason why you are doing these antigen tests. The use of the antigen test is important to have an algorithm. And that way you know exactly what to do if this is negative or this is positive. The antigen test can be done on the nasopharyngeal or the anterior nares specimen. And it's very much, it's like the test is being done as the pregnancy test. And you could see here the steps follow. And currently there are about 37 tests approved by the FDA and the emergency use authorization. So this is the algorithm that I was mentioning to you. So, and this is very important to have, especially when you are using these, especially when you are using the antigen test. And that way you can classify your patient symptomatic, asymptomatic, and close contact with COVID-19, and asymptomatic and non-exposure. And based on all these possibilities, you can classify to infected with SARS-CoV-2, no current evidence of infection, and not infected with SARS-CoV-2. And remember, this is a combination of using antigen test and with the NAT or PCR testing. Okay, so now the serology or adaptive immune response test. There are about 90 FDA under emergency use authorization serology tests for SARS-CoV-2 infection. And this, the majority target the spike and or the nucleocapsid. And so the antibody test usually is given at least 3 weeks following the onset of illness. This is not going to be positive at the acute phase of the illness. And so, and again, the various study sometimes detect IgG, some other time detect IgM, or together. And so remember the IgG, usually they raise more slowly, but also decrease more slowly. IgM is faster, the rise, and then the decrease. And the persistence of detectable antibody could vary based on the test used. And most of the time they use the test, which is called neutralization test, which detect antibody blocking the virus and the cell virus receptor. So the indication, most of the time this is used to support the diagnosis of COVID-19 illness or complication of COVID-19, especially in those who have the symptoms, but then the viral test was not available at that time. And then the patient now, you really need to know if the patient had COVID-19. And those situations sometimes could be in a very complicated patient in the case of the multi-systemic inflammatory syndrome. The interpretation, the other important equation is to interpret is to know if somebody has been vaccinated or not. And so, and this is just show here, in case of the patient has been vaccinated or not, what would be the interpretation? Because remember, the vaccine, most of the vaccine, especially that we use in the United States, they is based on the spike protein. So therefore, the antibody, you are going to have the anti-S antibody. So if the patient has been vaccinated. But if you have the anti-nucleocapsid antibody, you know that the patient, has been infected. So therefore, in vaccinated patient, if you have anti-S antibody and anti-N antibody, so it could be that the patient was infected. But if the patient was not vaccinated and the patient has anti-S and anti-N, so most likely the patient was infected. And if this is negative, meaning the patient was not infected. So that is the very quick interpretation, especially this is coming. If you don't have these yet, it's coming because there's so many of these being produced now. What are the indications for testing for SARS-CoV-2? Test for SARS-CoV-2 by PCR in sick patient, and those are the patient with febrile neutropenia. We suspected COVID-19 is going to be the fever, cough, shortness of breath, of new oxygen requirements, or throat, coryza, new loss of taste or smell, headache, GI symptoms, myalgia. And again, your classic, it could be just your classic febrile neutropenia patient. So when do you repeat the SARS-CoV-2 after negative test? You repeat if the patient, especially if the patient is negative test, but then has a new or worsened respiratory symptoms, or the patient has a persistent respiratory symptom in a recent negative test. But if the patient has persistent non-respiratory symptom, like diarrhea, for instance, in a recent negative test, so possibly in that patient is not necessary to retest, especially in the context of hospitalization. So now, another question they ask me is, what about the prolonged shedding? So for that, I want to share you two situations or two about two patients and then another patient. So the prolonged shedding in this particular one, these are in two patients who had an oral pharyngeal swab, and they have a PCR viral culture, and then also they have the full genome sequence of the viral isolated. And so the patient number one, and you could see here, what you are seeing is that the line indicate that the patient persistently had positive PCR, and then the red bar indicate viral isolation. And so, and you could see that the patient continue being detected PCR, but the viral test, the culture was not positive. And these are in the two patients. But the important part is that in these two patients, the isolation of the virus occurred past the regular 10 days that normally, it is recommended to stop the isolation. And these were immune-compromised patients. So remember that in immune-compromised patient, not automatically past 10 days, the patient stops shedding viable virus. And this study demonstrated that this patient can continue shedding viable virus. And in this other study was from a lady with also immune-compromised with cancer. And so she continued shedding for a prolonged time from the upper respiratory system, SARS-CoV-2. And so she shed up to 70 days. And so genomic and subgenomic RNA studies were available up to 105 days. And the infection cleared after 2 transfusions with convalescent plasma. And so what we saw in this reading, of course, is that there were a genetic variation of the virus being isolated from this lady. And so, and the conclusion is that some immune-compromised patients may continue shedding longer than previously recognized. And it could happen that the virus might evolve during this prolonged shedding. Okay, now co-infection. Co-infection in cancer, and this is another thing also they were interested, and remember that these febrile neutropenia patient can come, and of course you're going to be doing all the studies, the regular febrile neutropenia management in these patients. And just to remind us about co-infection, I just want to briefly review with you about this publication that I collaborated with my collaborator in Lebanon. And so this is the prevalence and characteristic of acute respiratory infection in pediatric cancer patients. So we follow all patients with respiratory infection, and we obtained 89 nasopharyngeal swab from patients with pediatric cancer. And so we did RT-PCR, confirming viral infection in 77 swabs, which was 86.5%. And so we found 151 respiratory viruses. RSV was the most frequent one, 45.45%. Then parainfluenza, followed by flu B, and then human metapneumovirus, and then also human coronavirus. They were almost 1/4 of them. Co-infection was in 55%, like half of them, and most of them involved RSV with one or more viruses. So there was a correlation between PIV, which is parainfluenza, flu, RSV, and human coronavirus with the incidence of co-infection. And you could see here the various type of viruses, and then the presence of mono-infection and co-infection. And you could see that 50%, in 50% of the situation, there was co-infection. And in this other graph, indicate the seasonality of this. And again, usually this is seen more often respiratory virus in the colder weather. Okay, so now what about in cancer patient? What about in COVID-19 patient? So in this study, which is on my left-hand side, the COVID-19 was studied in over 7,000 pediatric patients, and that was a systematic review of published study. And so they found the co-infection in 5.6% of children. So therefore, co-infection occurs. And then in our registry with the SIOP in St. Jude, we found in over 1,700 children with cancer, 7.9% there was co-infection. And the important part of that is that half of those patients had positive blood culture. So therefore, if you see a patient with COVID, febrile neutropenia, you just do anything that you normally do with febrile neutropenia, check for blood culture, because there is a possibility of co-infection. Okay, what about outcomes? And I know that I'm getting to the top of the hour. So in regard to outcomes, for that, I just want to review some published study in children with cancer. And this is from Dr. Millen from the UK. So when his group, he wanted to produce evidence of the incident and outcome from SARS-CoV-2 in children with cancer attending all hospitals throughout the UK. So basically, he worked with 20 treatment centers in the UK, and all eligible patients were tested positive for SARS-CoV-2 on RT-PCR, and the primary endpoint was death, discharge, or end of active care for COVID-19 for those remaining in the hospital. And so this is what he found. He found during this time period 54 cases, and he found that 28% were asymptomatic, 63% had mild infection, 10% moderate, severe or critical infection. During this time, no patient died, but 3 patients required ICU support due to COVID-19, and the estimated incidence of hospital-identified SARS-CoV-2 infection in children with cancer under 16 was 3%. And so what he ended up saying is that children with cancer with SARS-CoV-2 infection do not appear at increased risk for severe infection compared to the general pediatric population, and these findings support the continued delivery of standard treatment. And remember, this was in the UK. So now, what is our experience beyond that globally? And this was a data we gathered from 131 institutions in 45 countries, de-identified data of patients less than 19 years in cancer or transplant. And so we gathered some specific data for demographic, oncology diagnosis, clinical course, and cancer therapy. And the primary outcome were disease severity and modification to cancer-directed therapy. So even though the study continued, so we analyzed 1,500 patients, and so over 1,300 patients complete 30 days follow-up. So what we found in this group was almost 20% of patients had severe or critical infection, and 3.8%, unfortunately, of these kids ended up dying with the cause attributed to COVID-19. And but also 55% patients were receiving active oncologic treatment that needed to have their cancer therapy modified. So what we learned was importantly that, because remember, these are registry that our collaborator contributed from around the world. So they show that depending where a patient is, the factor associated with severe or critical illness is, for instance, the country of origin, low income or low middle income country, and then also the age. So usually those age 15 to 18, they have more severe illness. The ALC, the absolute lymphocyte count, as I mentioned to you at the beginning with the other study, this was kind of confirmed the cytopenias, the cytopenia which indicate immunodeficiency, and especially the lymphopenia. The absolute neutrophil count, meaning a neutropenia, it could be a marker of the lymphopenia and the intense treatment. But then also there were other factors associated with treatment modification, and again, the country of origin, the diagnosis of other hematologic malignancies, and then also the presence of one or more COVID-19 symptoms and other comorbidities. What about treatment? And so regarding treatment, very important thing to do because usually these are not, resources are very limited. So very important to assess COVID clinical presentation. Does the patient respiratory symptom, is it upper or lower? And does the patient require critical support? And then important to assess the potential for COVID to progress from upper to lower. And usually it's important to check the status of the T cell immunodeficiency. And then other risk factor, obesity, pre-existing severe lung disease, hemodynamically stable or not, pre-existing disease where hypoxia can carry severe consequences, like for instance, sickle cell disease. And based on that, the treatment that normally is provided is antiviral, and this is the dosage. Usually is in less than 12 years of age, still is under the emergency use authorization. And usually this is intravenously given, and this is in addition to the regular treatment you give for febrile neutropenia. And then the association with dexamethasone. So in patients who cannot receive dexamethasone, you can give an equivalent, or for those who have access to other type of anti-inflammatory medication, also you could use that. So now there is the monoclonal antibody therapy that you could use for those who were exposed to COVID or not too sick, not being admitted for COVID. And these monoclonal antibodies they have specific indication. Usually it's given for those over 12 years of age and over 40 kilos. And these are in blue, in the blue color. It says not fully vaccinated and expected to mount adequate immune response to complete SARS-CoV-2 vaccine, exposed to SARS-CoV-2 or high risk for exposure, and one of the risk criteria for severe COVID. So I think that the key information here is to really assure that you classify who are going to have severe COVID based on the risk factor. And that's it. So thank you so much for your attention. And I'm sorry that I wasn't able to answer everything, but this is a time limit. So thank you so much.
Fantastic. Thank you so much. And I think there are a bunch of questions in the chat box. And I think I don't know how much time do we have. Could I get an idea of how much time do we have to go over these questions and answers? If someone could type those in the chat box, that will be helpful. Otherwise, we'll quickly see. So a lot of questions are directed towards our physical medicine and rehab colleagues, and I think there seems to be a lot of interest in this group, in this, you know, in their being a part of the pediatric oncology community and being, you know, taking part in children with cancer. And I think a lot of folks are asking regarding how to join this. And I think a response has been posted as to going through the SIOP website in order to eventually participate. Otherwise, I think, are you all able to access the question chat box? Okay, wonderful. Maybe you all can share your email address, and that way, you know, if there's someone who directly wants to get in touch, they can do so. You know, I mean, this is very encouraging. And then there were a couple of questions directed towards Sarah, and there was a question regarding the threshold of platelet and blood transfusion in aplastic anemia. Sarah, would you like to answer that question?
Sure. I'm just opening the live chat box slowly. Should I just answer them in the chat? Is that okay?
Sure. That would be fantastic. And while Sarah is typing the answer, Miguela, I think there is a question over here that's posted regarding the characteristics of COVID infection, particularly with the Delta variant. Would you like to comment on that?
Yes, the infection is basically very much the same, but it looks like there is many more viruses, and so that's why people think that it's much more contagious. But the good part is that the remdesivir and even the monoclonal antibody, they're still very efficient for that. So. And again, when you are talking about about SARS-CoV-2, they talk about the variant, and the variant are kind of like the modification that the virus undergo. And so, the important information about this new variant is that how good are these vaccines, and then how good are we going to be able to help with the current medication we have. And for the Delta, the answer is yes. We can deal okay with these resources we have.
Okay. I think there is another question, Miguela, regarding the type of testing that you recommend for patients that are on chemotherapy. And I think you probably covered that in your talk. But maybe if you can answer this question. They're asking regarding antigen versus PCR. Particularly in the low middle income setting, what would be the testing modality that would be ideal?
Yes, the antigen testing, again, you need to have an algorithm, because then you need to know what to do, because the antigen is less sensitive to the PCR. And so it could be that the antigen test will be helpful if this is positive. But then if this is negative and you still suspect strongly that this could be COVID, you might still need to go ahead and do the PCR testing. So that's why I'm saying, you really need to check how are you going to be proceeding with that, because it could be that, the COVID test is negative, but you still feel like this is positive and you're going to still be intervening in that patient.
Sure. Fantastic. I think there is a question that maybe our rehab colleagues can answer. And this question is particularly regarding rehab in low-income countries where resources are limited and the majority of children are severely malnourished. What sort of recommendations would be for these children?
Hi, thank you, Sadaf. I think I can answer that one on behalf of us all. So there's a couple of questions actually in the chat about dietetics and nutrition. So they link quite closely together. And that specific question, so thank you to whoever has asked it. We, as a new group, haven't yet formulated any guidance, but we welcome people to get in touch with us. We know as a new group, that's exactly what we need to do. Rehabilitation isn't a bubble. It will have to work with many other groups, and nutrition will be one of those groups. So in order to develop things moving forward, we would invite different groups to come forward. That's certainly one of our aims, to work with existing groups so we can start to develop things together. But the point is absolutely accurate in that we would have to take serious consideration when providing rehab with malnourished groups of people, be them children or adults, but developing something moving forward would be a really sensible idea. There was also a comment about dietetics involvement. And again, we didn't purposely leave dietetics out. It's just they have already a presence in SIOP. They're recognized as being integral. So we actually have a lot to learn from anybody involved in nutrition and dietetics, but absolutely we would be happy for them to be involved with anything we do moving forward.
So one thing that I wanted to, briefly bring up, particularly regarding physical medicine and rehab, and even in the developed world, it's not as commonly available. to pediatric oncology. And I feel that at least one of the suggestions that I may have is we use parents as our allies in terms of, involving them and teaching them what you all would be doing, and so would you like to comment on that maybe?
Go ahead, Pia.
Okay, I go. Yeah, sure. So, of course, parents and families and brothers and sisters, as I mentioned in the presentation, are our allies. We have had the experience that while we're treating one patient, another parent asks us why we're not treating theirs. So they become the advocacy, part of the advocacy of rehabilitation, and what it entails in the quality of life that gets survival for pediatric cancer patients. So we definitely encourage all parents that if they have doubts, if they want to get involved, even if they cannot get access to rehabilitation in their settings, they can still do something, and to feel free to contact us, and we can help them. But parents and families become our allies while doing therapy, so they're a key factor in getting this task forward.
And it's an absolute correct point, Sadaf, that it doesn't really matter about the setting. Obviously, high income settings are generally better resourced, but you're absolutely correct that it is not always the case for rehabilitation. So we have many examples of high income settings that do not have universal coverage of rehabilitation. So our work is absolutely focused on trying to even the gap globally, and we would like to support particularly low middle income countries, but we will look to try and focus on anywhere where there's a need for rehabilitation, wherever that is.
Fantastic. Miguela, I think there is a question for you regarding treatment of COVID with chloroquine and azithromycin, and would you like to briefly comment on that?
Well, the chloroquine, I see that the chloroquine, they did not really found enough evidence for that. And so it looks like the medication so far that it is efficacious is the remdesivir. And again, that was a classic study that showed that the time of recovery of the patient was decreased. So the chloroquine, I don't think that we have enough evidence. The patient might have a side effect from that, and we do not recommend. So now, azithromycin, the azithromycin, especially in the context of a respiratory infection, remember that the patient can have co-infections. So if there is an indication for a co-infection, where you want to use azithromycin, it will be helpful. And specifically, like for instance, patient with sickle cell disease. Patient with sickle cell disease sometimes come, which is called the acute chest syndrome, because COVID can produce acute chest syndrome in these patients. And azithromycin is part of the regimen because they could have atypical bacteria like mycoplasma producing that. So azithromycin is helpful for that. And again, if you suspect any atypical organism, azithromycin is good. The other important thing to remember is azithromycin is an anti-inflammatory. So it could be that at the end it's going to be okay, but you need to have that indication. It is not indicated for COVID by itself.
Thank you. Thank you for that. I think we have covered almost all the questions. And I'm really, I felt this was really a great learning session where so many different aspects of care of children with cancer was covered. And if you all would have a comment, I think we have a few minutes. And the floor is open, so I'm opening it for any one of you to make a final comment before we sign off.
Again, thank you so much for this opportunity and to being working together with Sadaf in supportive care. We are really, I think I could say we are enjoying this and able to really, how can I expand the range of help that we could give. And thank you again for our speakers and everybody who is participating in this forum. And from the infectious disease viewpoint, and we know that we are still not out of the pandemic, I would just encourage you to vaccinate, and then and hopefully the approval is lowering, and that way you can vaccinate also to the younger kids. And we are thrilled to see that in some countries the rate of mortality is going down. And this is I am sold to the idea of the vaccine. So please vaccinate whenever you can. Thank you.
Fantastic. Thank you. Thank you, everyone. This was really, really great. And I really, really look forward to many more such sessions in the future.